Welcome to the fifth episode in this 8-part case series on advancing the standard of care with cellular and tissue-based products. This series is brought to you by Smith & Nephew. I am your host, Dr. Harry Schneider, Assistant Professor of Surgery at Harvard Medical School and Residency Director at Cambridge Health Alliance Department of Podiatry. In this episode, Dr. Charles Parks, Assistant Professor, Podiatry, Trauma, and Problem Fractures at University of California, San Francisco, will be presenting a case on the use of placental and umbilical tissue in wound care.
Hi, welcome everybody. Here's a quick case study on one of my patients from San Francisco General Hospital and Trauma Center. It is a post-op infection in an immunocompromised patient. So here we have a 48-year-old patient with HIV and bipolar and substance abuse who underwent a Liz Frank ORIF. So he came in about 6 weeks prior to this with a Liz Frank fracture. He was on his drug of choice, and he presented about a few weeks after his injury, trying to do the lesser of two evils. We chose to do almost like a CRPP. But unfortunately, he lost the follow-up and went again back to his substance abuse and showed up into our ED about 6 weeks after his ORIF or CRPP with this looking foot on the left photo. After a quick debridement in the ED, this is what it looked like. So he had a post-op infection, deep space all the way down to kind of bone and hardware. And he did end up undergoing 6 weeks of IV nafcillin generated with cultures. So first he did a OR debridement and vacuum, and he has these two remaining large kind of medial and dorsal wounds. The dorsal wound is down to the Liz Frank complex with a joint and kind of bone exposed. Again, chose to place a STRAVIX on, as you can see, fenestrated the STRAVIX, stapled it in, and put a vac on, and I bridged the two wounds together in the vac. It stayed on for, the vac stayed on for 1 week, and here you can see on the right, the STRAVIX is incorporating already within 1 week. At 4 weeks, you can see that the dorsal wound is fully granular, and it's at the level of the skin instead of, it has no depth to it, and the medial wound already is getting smaller. At 2 months, you can see the medial wound is about the size of an eraser head, and the dorsal wound is fully granular still and smaller again. 2.5 months, so this is a picture at 3 months, but 2.5 months, the medial wound closed, and that dorsal wound is now the size of a dime. And then a complete closure of both wounds here at 4 months. So again, he had a 48-year-old male with HIV and polysubstance abuse who had an infected Liz Frank fixation. There was 92% reduction surface size in both of the wounds after just 1 month, after 4 weeks of the STRAVIX application, and complete closure of both wounds within 4 months. You actually had the medial wound close in 10 weeks. Thank you for tuning in and listening. And again, was a post-op infection patient of mine and immunocompromised with the STRAVIX application.